بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. آمين يا رب العالمين وأجمعين. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. آمين يا رب العالمين. I still continuation of the chest imaging made easy course lectures, and we are still in the dominant abnormal pulmonary patterns, and we have the last pattern. It is airway in this lecture. We can classify the airway in the major, large, and small, and the mechanism either wall thickening or obstruction, either complete obstruction or partial obstruction. The airway patterns can be mechanism, can be complete obstruction, as we said, obstructive atelectasis, collapse, or partial obstruction, airway trapping. Thickening of the wall, this is another mechanism, and small airway disease, mixed obstruction. And airway pattern can occur in the small or large airways. Features either complete, if it is complete obstruction, produce obesity and decreased volume of the lung due to site of obstruction, may resemble, as we said in the previous lectures, collapse, may resemble localized consolidation, but without air bronchogram. Can be Other pattern can be partial obstruction, produce lucency and increase in volume, and we will see some examples. Here, patient with obesity with no air bronchogram in the upper mid zone associated with hilar enlargement, and it is due to bronchial carcinoma of the left bronchus causing left upper lobe collapse, and this is obstructive atelectasis. You see also the secondary signs of collapse, elevation of the left hemidiaphragm, and we see here the mass lesion in the anterior part of the anterior segment of the left upper lobe. And here we see patient with partial obstruction, and we see air trapping, and there is air trapping on the right lung, and this is the left lung, and we do the decubitus, and the decubitus is still there is air trapping on the right lung due to foreign body obstruction causing partial obstruction. Airway patterns, differential diagnosis. Uh, we have complete obstruction either due to mucus plugs, foreign body, and the general diagnosis of masses. If it is partial obstruction, we have the COPD and pneumatoceles, bronchial wall thickening, either acute or chronic bronchitis, bronchiectasis, and a bronchiolar small airway disease obstruction. We have the mass general general differential diagnosis is the masses causing obstruction, either primary or metastasis, lymphoma, malignancy, granulomatous disease, either infectious or non-infectious, inflammatory disease, non-granulomatous like infarction, pneumonia, abscess, benign or malignancy. Wall thickening of the airway can be seen in the bronchitis, acute or chronic, and can be seen in the bronchiectasis. We have dilatation and distorted lumen, and we have the bronchiectasis can be cylindrical, varicose, and or cystic, or mixed. Large airway, we have central rings, we have tram tracks, and we have some examples. Bronchiectasis can be central rings, dilated large bronchi. Central cystic spaces can be irregular and diffuse air trapping. Bronchial wall thickening, we have tram tract appearance and central circles, and bronchial small airway obstruction, and we appears as nodule. It is irregular in size and shape and distribution, and small irregular locenses. In this patient, we have bronchial wall thickening, as we see here and there and here, and appear as circles between the appears as circles, as we see here. And also here we have the bronchial wall thickening with between the heart and the spine, and it is appears as a tram-like appearance. Bronchial wall thickening, as we see here, we see here, we see here. Bronchial wall thickening also can be causing in the with high resolution CT scan, and this will be discussed in some details in the CT lectures. And we have can be bronchial wall obstruction due to bronchial, endobronchial, or compressive causes, partial obstruction, localized air trapping, and bronchial wall thickening, thick walled bronchi, trams, and signet ring. Bronchular, small airway, and we see ground glass opacities and the tree in bud. Here, patient with the bronchiectasis, and we see tree in bud appearance, as we see here, with some ground glass appearance, and we see some bronchial wall thickening, and with tram-like appearance, and some signet ring appearance in some areas here. Here, tree in bud appearance. Here, tree in bud appearance with some ground glass appearance. Here, another patient with bronchiectasis, we see bronchial wall thickening with tram appearance, with the regular wall thickening with some ground glass appearance involving most of the upper lobes. Small airway disease can cause mixed obstruction, either partial or complete obstruction. Bronchular, small airway obstruction can cause nodule, as we said. It is irregular in size, shape, and distribution, and small with small locenses. Here, patient, we have a small airway disease appear as irregular batches, different in shape, with different in shape and densities, and it is different from the interstitial lung disease. And this patient has hypersensitivity pneumonitis, and we have also the here irregular nodules patches involving the with the zone spot here. Here, another patient with nodule with patches with the ground glass appearance involving both lungs. A bronchial obstruction is small airway disease, can be specific differential diagnosis. We have infection, especially viral, mycoplasma, and fungal. We have allergic hypersensitivity pneumonitis, as we see in the previous example. We have the toxic, and we have chlorine and other materials. We have post-transplanted graft versus host, and we have aspiration, and we have the idiopathic, and this we will tackle on it on the CT lecture. Thank you for listening, and hoping to see you soon on another in the continuation of the chest imaging made easy course. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.